Normal blood pressure is completely dependent on your size and your age to a small degree, but mostly on your size. For example, the blood pressure in a little baby might be 60. But blood pressure, the normal adult who walks into our clinic, a perfect blood pressure would be like 120/60. We worry when the diastolic blood pressure, the bottom number, is over 90 and stays over 90. Why do we worry about that? Because that places a consistent, constant load on the heart, and the heart thickens. The upper number, the systolic number, so if I told you your blood pressure is 170/100 today, that would mean that the patient has both systolic top number and diastolic bottom number hypertension. And in my opinion, in the past, the patients with very, very high systolic pressures are those that are more prone to have a stroke in the near future, a mini stroke, a major stroke. But that bottom number keeps the heart, it makes the heart get thicker and thicker. So both are bad if they're high, but don't run around with a diastolic blood pressure of 90 or a systolic blood pressure of greater than 140 or 45. Keep them below that. When we hold the arm out and take the blood pressure, we try to measure the pressure relative to the height of the heart. Should be about, the artery that we're measuring should be about the level of the heart. So when a person is lying in bed in a hospital bed, it's easy because they're at the same level. The blood pressure is the number of millimeters of mercury higher than that level of the heart. And the reason there's a systolic and a diastolic is because the systolic pressure is when the heart's ejecting. Now, you've seen these TV screens where they're doing surgery and all of a sudden blood shoots all over the room under high pressure. That's under systolic pressure. Very high. 120 millimeters of mercury is a pretty high column. A couple hundred millimeters of mercury is a very, very high column. Venous pressure in the body should be very low. It should be 8 or 10, as opposed to the very high arterial pressures. That's the systolic pressure, and that's when the heart's actually ejecting, contracting. That's when the heart's relaxing. That's called diastole. Nerve conduction velocity, electromyography, is a test in which, as I mentioned before, the way we measure nerve function is by the amplitude and the velocity. And with very sophisticated equipment and the right person doing the exam, we can measure exactly how long it takes a nerve impulse to get from A to B and how high that nerve impulse is between A and B. It's really crucial in our practice because the patient who comes in with hand or foot pain may not have neuropathy. They may have radiculopathy, cervical disc disease problems. They may have lumbar radiculopathy with lumbar problems. They may have just a pure toxic problem. They've had chemotherapy and all their nerves are damaged. All of those things will show up on the nerve conduction test. In addition, each nerve tested is separate. So each major nerve in the leg can be tested. The 2 major nerves in the hand can be tested. The test will show if there's also compression, such as carpal tunnel syndrome. The test will show if only the coating of the nerve or the nerve fiber itself are damaged, one or both, either or. And as far as the EMG, that will tell if there's also muscle damage. And when nerve conduction has been delayed for a long time, and sometimes when there's severe compression, muscle damage is significant. Muscle denervation is significant. Once the nerve tissue, once the nerve supply is not good for a long enough time, the muscle starts to die. So this test has not in the past, by most people, considered to be a prerequisite for treating neuropathy. And because of that, there's not a tremendous amount of literature saying this test has to be done before you treat a neuropathy. But in actual point of fact, it's a very, very good test for a differential diagnosis of many of our hand and foot pain patients. I'll tell you the reason where the pain is coming from.